Hello.
Good evening, everyone, and
Good evening,
welcome
Ashim.
to. Good
Ratan
evening.
here.
Yes. Welcome, Ratan. So, good evening, everyone, and welcome to
Hi,
Mahamana
Akshat.
Case discussion series.
Hi, Ratan. Hello, Asim.
Hello.
Hi. Good evening, Komal and Sunena.
So, we'll be starting with our session on the carcinoma larynx. And for the invited talk, we have Dr. Akshat Malik, who is a senior head neck surgeon at Max Super Specialty Hospital, Saket. And he'll be discussing on the swallowing function assessment in laryngeal cancers.
Right. Thanks for the introduction, Asim. Can I be allowed to share my screen? I'm not able to share my screen.
Just a minute. You can share now. I'll request everyone whoever is joining to please keep their muted once they join.
Right. So is my screen visible to everyone?
Yes, Akshat.
All right. Should we start or you want me to wait another?
Please start. Please start.
All right. All right. Well, good evening, everyone. Like Asim mentioned, my name is Akshat Malik. I'm a head and neck cancer surgeon at Max Saket, Delhi. And today I'll be talking about functional evaluation of patients with laryngeal, and though Asim didn't mention, but also hypopharyngeal cancers because they have got similar functionality and assessment techniques. So first of all, we need to understand what are the functions of larynx. Number one, it prevents aspiration. That is the main function. Rather than speaking, that's the main function. It aids respiration. It helps in speech. That is how you speak. And it helps in swallowing as well. So larynx is all powerful for these problems, these issues, mainly for aspiration, speech, and swallowing. Now, what is the need for pre-treatment evaluation? You see, there was this assessment done at Tata. This was published by JP Agarwal, sir, where we found that pre-chemoradiotherapy, about 1 in 5 patients may be having aspiration, 23% patients may be having pharyngeal residue, 20% patients may be requiring change in posture. They may be even suffering from regurgitation. And on further evaluation, they may be having penetration aspiration scale may be poorer in these patients and up to 1/4 of them. So as you can make out, these are quite high numbers. They are substantially high. 1 in 4 or 1 in 5 patient having such a problem means we need to intervene early and we need to take care of things, or at least help them so that they're able to sustain through the treatment part easily. Now, there are different studies where they have tried to evaluate swallowing function. As you can see on the screen on the left side, based on aspiration based on the site. This paper was published about 15 years back, and there they mentioned that up to 1/3 of laryngeal cancer patients may be having aspiration. And pre-treatment swallowing assessment in other places also, the problem is much higher in larynx and hypopharynx compared to oral cavity or oropharynx, and more so, of course, in extensive resections, extensive diseases. Now, when should we be considering it? So, like I mentioned in the previous study, which was done in Tata, we need to be doing this initially only, so that we are aware that what the swallowing of the patient is, and we can take care, we can decide on the treatment and exercises as well as interventions which are required upfront. We can start with prophylactic exercises, and there are several studies which have shown that if patient starts with these things, then their swallowing is maintained even later on. So this is very essential part which we need to understand. Besides this, there are certain triggers for dysphagia evaluation which have been mentioned. As in, you need to send all patients for swallowing assessment, but still, at least in these patients, you should be definitely sending them. Inability to control food, liquid, saliva, and oral cavity, pocket of food in cheek. So this is not only for larynx, but it also includes patients with oral cancers. I'll be specifically mentioning those with laryngeal cancers one. So drooling, coughing, choking, throat clearing. Patient may swallow, say, few seconds back or 15-20 seconds back, but they may still have cough later on. That may be because of valvular residue, which is dribbling down into the larynx. They may have abnormal voice quality, wet voice, or buildup of congestion after a meal. They may have difficulty after swallowing. They may feel the throat is choked. Complaints of food sticking in throat. Sometimes nasal regurgitation may also happen because of other involvement. And of course, weight loss. So these should be the definite triggers for dysphagia evaluation. But like I mentioned, even for patients otherwise, all patients should be going through a speech swallowing therapist before we start treatment. How it helps? Number one, if you're talking about laryngeal cancer, then if it's an advanced stage disease and patient is having aspiration, we will call that probably it's a dysfunctional larynx, and we may consider surgery for such patients. There are also a couple of publications where they've mentioned that in such patients, you may try neoadjuvant chemotherapy. And if the swallowing function is improving, you can go ahead with chemoradiation. But then if it's deteriorating, then probably you should be considering surgery. Swallowing rehab, we have already discussed that needs to be brought on board early on. Need for intervention. So many times, patients will keep on saying, okay, we're able to swallow. But then when you actually go and assess them, their nutritional requirements are not being met. They are not able to swallow properly. So there will be need for having a feeding tube inserted or probably a PEG tube inserted. And at times, even a tracheostomy. Because aspiration, if it goes uncorrected and patient is going ahead with chemoradiation, you can imagine the patient will have pneumonia. And even with radiation, it may lead to treatment interruptions, and which we don't want. So if patient is having gross aspiration on assessment, then we should be considering tracheostomy tube for such patients as well. Now, how do we assess this? Number one, through the weight. If the patient is having substantial weight loss, we say 10% of the previously known weight. If it has come down, then we call it a substantial weight loss. Need for feeding tube. This could be a PEG tube or a Ryle's tube. Then there are few bedside examinations which we can do. We can ask the patient to speak out, which will help us in knowing whether the tongue is moving fine or not. Any coughing, choking during or after swallowing. This can also be indicator of airway penetration aspiration. Gurgly voice quality, that means that there is some accumulation which is happening near the larynx. Sticking sensation at the back of the throat, regurgitation. Long time to initiate swallow. They may not be able to swallow early on. They may take a lot of time. They'll be having pain. They'll be restrained, and you will get to know. So this may be because of pharyngeal involvement in such patients. Now, this test was previously used at many places, but I think now it has probably died down. But still, you need to be aware of this, the blue dye test. This is more so important in tracheostomized patients. Many times people are on uncuffed tracheostomy tube, and you give them this blue dye, and probably you will see dye coming down from the side of the tracheostomy tube or through the secretions, which is indicative that patient is having aspiration. So this is a good way to assess that. So like I mentioned, you can give a food saturated with blue color and ask, close the tube before the patient swallows, ask the patient to swallow and observe for next few hours. If there is presence of any blue food in the tube, that means the patient is aspirating. Then very simple, which many of you would have heard otherwise also, is the water swallow test, where we ask the patient to drink about 100 ml of water as quickly as possible. 100 ml is about half a glass. So any coughing or choking sensation, inability to complete the swallowing task, wet or gurgly sound immediately or afterwards. So the cough also and even the gurgly sound can come after some time, because what happens is, say there's a substantial bulky disease, it may take time for liquid to really pass down into the larynx. And we call swallowing volume as ml swallowed by number of swallows taken. So you can understand how much is the swallowing volume, and swallowing capacity is the ml swallowed divided by the time taken. So these can help us in quantifying how much is the swallowing dysfunction with the help of water swallow test. This is a very simple and basic test, and I am quite sure majority of us would be using this for assessment of these patients. And this is reasonably sensitive. More than 2/3 of the patients are easily picked up on water swallow test. Specificity may not be that good, but it is quick, simple, and not costly. So it's a good way to assess these patients. Next come FEES, functional endoscopic evaluation of swallowing. And in this, we give the patient semi-solid, liquid, and solid of different, that means different consistencies. And we are using a thin fiber optic scope, which is placed at the level of nasopharynx only. We don't generally tend to go down as we would do for laryngeal examination, because that hinders with swallowing. But just being there at the nasopharyngeal level and evaluating swallowing from there. Now, what all are we looking for out here are, number one, valvular residue. As you can see in these pictures, the upper picture is showing valvular residue. So because we are giving colored foodstuff, any coating of the valvula is indicative of valvular residue. Now, how do we quantify it? You can see on the table on the right side, if it is just trace, that is 1 to 5%, we just say there's trace coating. If epiglottic ligament is visible, but it is still appearing to be more than just minimal, then we will call up to 5 to 25%. If epiglottic ligament is not visible, all the food is coming out there. As you can see in the picture, the fourth column out here, then we say it's 25 to 50%. Severe will be, there'll be the epiglottic rim will also be covered by the food stuff which is there. Then we come on to pyriform residue. Pyriform residue means the food stuff will be collecting in pyriform fossa. The patient is not able to gulp it down the esophagus. So there again, depending on the extent of coating which is present, whether there is trace coating or pyriform fossa is just getting filled up, or it is more than half full, or it is reaching till AE fold, accordingly the severity will vary, and that is being mentioned in this slide out here. Then we can grade this, we can grade aspiration based on Rosenberg's penetration aspiration scale. So grade 1 is material is not entering the airway. After that comes penetration. Penetration means it is going into the airway, but it is being ejected out. The patient is coughing it out. So depending on where exactly it is. So number 2 is material enters the airway, but remains above the vocal cords. It is above the vocal cords, patient's sensation is present there and he's able to cough it out. Number 3 is it is above the vocal cord, but patient is not able to eject it out. Number 4 is it is reaching the vocal cords and it is being ejected. Number 5 is it is touching the vocal cords, but it is not being ejected. So above vocal cord, ejected, not ejected, reaching vocal cord, ejected, not ejected. After that, as soon as it crosses the vocal cord, we call it aspiration. Before that, it was penetration. So number 6 is material is passing below the vocal cord, but it is ejected out by coughing. Number 7 is it is not being ejected. And number 8 is, which is the worst, of course, that the material is going inside and the patient is making no efforts at all to try and bring it out. So that is the worst swallowing which we can expect. We can even do video fluoroscopy. So penetration aspiration scale works for both fiber optic endoscopic evaluation of swallowing as well as video fluoroscopy. And as you can see out here, I'll play the video for the benefit of people, those who have not seen. So we have given this dye to the patient. We generally give gastrografin dye because it is, even if it goes to lungs, it is not harmful. So you should be aware of ionic and non-ionic dyes. As you can see, this is the material trickling down into the trachea. Now, besides this, we can also assess the quality of life of the patients. So for swallowing related quality of life, you would have heard of MD Anderson dysphagia inventory, MADADI score. It assesses swallowing based on a global score, emotional, functional, and physical score. And we take a mean value, which is multiplied by 20. And based on that, we grade these patients. This is what the evaluation score looks like. There are simpler ways to do that. MADADI is big, extensive or exhaustive. There's a simple E10 questionnaire which you can use. This is also a simple questionnaire and patient can just mark it out what problem, how much problem is he having. Then there's a Sydney swallowing questionnaire. This is also being used in quite a few studies nowadays. And this also has got reasonably good reliability for assessment of swallowing. There's this another scale called as PSSHN, Performance Status Scale for Head Neck Cancer Patients. Here we ask them to grade the problems depending on what their severity. So like, as you would know, patients have problem in eating in public. So if there's no restriction, then we give them a score of 100. If they're only able to eat at home, then probably it's 25. Then normalcy of diet, which was similar to functional oral intake scale, which I have come to now. So functional oral intake scale is also a very simple assessment. Number one is patient is not able to take anything by mouth. Number two is tube dependent, and sometimes they make attempts of taking things from their mouth. Number three would be that they are taking from mouth, but they are still tube dependent, and so on. And number seven would be totally normal diet. Patient is not requiring any extra effort. So that is number seven. So 7 is the higher value, which is better swallowing. So all these scales are quite simple and can be easily used in the clinics without wasting much time to assess the patient swallowing. Now that we have assessed swallowing, next we come on to voice. So voice can be assessed either through patient reported, or it can be a subjective assessment or a objective assessment. Stroboscopy can also be used. In stroboscope, we are shining light at repeated intervals, and that freezes the cord movement for us. So we're able to see whether there is any, inner involvement of the lesion, even if it's an early glottic lesion, then whether there's a deeper involvement or not. Then there is VHI, Voice Handicap Index. It has got a functional, physical, and emotional component. And there is a VHI 10 also, where instead of 30 questions, we are just having 10 questions, and we can just grade them on a Likert scale. And accordingly, we can understand how much is the discomfort. GRABAS is you are asking the observer to grade the patient's speech. So that is depending on the grade, roughness, breathiness, asthenia, and some people even add I component, that is the instability, whether the voice quality varies over a period of time or not. And this can again be graded as per a Likert scale. Then this may not be done routinely by oncologists, but this is often used by phoniatric surgeons. And this is vocal assessment through electroglottography. We put electrodes out here in the neck over the thyroid cartilage. And then when the patient speaks, the various parameters are recorded. Prominent amongst these are jitter, which is the frequency variation, shimmer, which is the amplitude variation, and fundamental frequency. That is the number of times the sound wave is produced by the vocal cords during a given time period. So these can help in quantifying how much is the voice deterioration. So as you would have understood, and by this presentation also through this cartoon, that larynx is not a plaything, of course. We are very much bothered because of the swallowing, aspiration, as well as the speech. And we need to assess all these things properly. So thank you very much. I would be happy to take questions if there are any. Asim, are you there?
So Thanks a lot, Akshat. And I think you'll join in for the case presentation. And if there are any questions that can be put up in the chat box, and we can discuss those points along with the case presentation.
Sure.
For the case
May I
presentation,
excuse myself in between. I'm sorry. I have.
no issues, please. Thank you, please.
All right. All right. Thanks a lot. Thank you.
So I'd like to invite the examiners for the case presentation. We have Dr. Purushottam Chavan. He's a professor of head neck oncology at Kidwai Memorial Institute of Oncology, Bangalore. We have Dr. Divya. She's a senior consultant and head neck surgeon in, I'm just sorry. From Government Medical College, Kannur. And we have Dr. Ratan Chetty. He's associate professor in head and neck oncology at ACTREC, Mumbai. For the case presentation, we have Dr. Arij Moinuddin. She is a MCH resident at All India Institute of Medical Sciences. Akshat, I think we have 3 questions in the chat box. Maybe you can answer them before, yeah, you can just take them before the case presentation.
Sure. So I'll just go through them. Which swallowing and voice evaluation score is most preferred? So voice evaluation, we generally perform VHI. VHI is simple and you can easily do it. For swallowing, there's a lot of variability. For initial assessment, I would do a 100 ml water swallow test. I would ask the patient to swallow. And in case of any doubts, I would probably perform FEES or VFS. VFS is more specific, but then it may not be available everywhere. And then, of course, there's a radiation risk. But then you can even do FEES and that can tell you how things are. Next question is, do you routinely use any of these scores for routine clinical assessment? Not normally. I would prefer to, but as a part of studies and trials, we of course document these. These are part of all major studies nowadays. You need to document the quality of life as well as the assessment part. I think these were the only 2 questions. Probably if anyone else also wants to ask, I'm happy to answer. I guess that's.
I think Arij, you can start the presentation.
Sure. All right, Asim.
Good evening, sir. Am I audible, sir?
Yes, please present.
Good evening, respected all. I would like to start my case.
You can just put your screen on the slide share mode. It's still on the presentation mode. Presentation mode, yeah.
Sir, can I start, sir?
Yeah, please go ahead. Good evening, sir.
My patient is a 51-year-old gentleman. He's a resident of Bagpat, Uttar Pradesh. He's a farmer by occupation. History is given by the patient himself. So he presented with chief complaints of foreign body sensation in throat for 5 months and change in voice for 4 months. History of presenting illness. Patient was apparently normal 5 months back when he started developing foreign body sensation in throat. It was insidious in onset and it gradually progressed so that he started developing pain in the left side of neck with pain radiating to the left ear. The pain was pricking tight and it subsided with oral medication, but it was not disturbing his routine. He also had complaints of change in voice for 4 months, which was gradual in onset and progressive in nature. It was associated with decreased intensity in the volume. There is no history of bloodstained sputum, noisy breathing, difficulty in breathing at rest or exertion, pain during swallowing or difficulty in swallowing or any neck swelling. There is no history of cough on taking liquids, pain abdomen, jaundice or any bony pains. There is no history of any significant weight loss or loss of appetite. Past medical and surgical history. There is no history of similar illness in the past. No history of diabetes mellitus, hypertension, ischemic heart disease, tuberculosis, COPD, bronchial asthma or any other comorbidities. No history of any surgeries or any prolonged hospital admission. Personal history, he follows a mixed diet, sleep is normal, bowel and bladder habits are unaltered. Addiction history, he has a history of BD smoking, 1 bundle per day for past 30 years, and which he has stopped since past 5 months. There is no history of alcohol intake or other tobacco chewing. Family history, there is no significant family history. Coming to clinical examination.
Can I intervene, Dr. Harish?
Yes, ma'am.
Can you please summarize the history of the patient? Just summarize the history.
Yes, ma'am. My patient is a 51-year-old gentleman. He's a farmer by occupation who presented with complaints of foreign body sensation in throat for 5 months, and it was insidious in onset and progressive in nature, which later progressed to develop throat pain radiating to the left ear. Along with that, he started developing change in voice for the past 4 months, which was progressive in nature, but not associated with any dysphagia or dinophagia, breathing difficulty or noisy breathing, or bloodstained sputum, or
may I ask you, what was his complaint? Started with a foreign body sensation, followed by throat pain with pain in the ear.
Yes, ma'am.
Okay. Yeah. After 1 month history, he developed change in voice. So, what was the change in voice he noticed? Is it the quality?
Ma'am,
how was the change in voice? How was the change in voice? Because after a foreign body sensation, the change in voice can be in different ways. Can you explain in which all ways the voice can change? The complaint started with the foreign body sensation. That is why I am asking this question. Because if it is a pucker, vocal cord lesion, or elsewhere in the surrounding lesion, the history of change in voice will be different.
Yes, ma'am.
Do you agree with that? Do you agree with that?
Yes, ma'am.
Yeah. Can you please explain about that?
Ma'am, so initially he had only foreign body sensation. Later on, he started having the quality of the voice was kind of rough, and the intensity of the volume was less. But
okay, so the quality of the voice, it was the roughness. It started with the roughness of the voice. So that means that there is something dealing with the vocal cord. So if it is an oropharyngeal lesion, it will be a hot potato voice, something in the throat. So the change in quality itself, the nature of the change in the quality itself will give where actually is the lesion. That is what I asked this question. So you said that the change in voice was first harsh and roughy voice. So you can pinpoint the site of the lesion by the nature of the change in the voice. So that point I want to bring in notice. That is why I intervened. Okay. Continue. Please continue.
Coming to general examination, general condition was fair. He is conscious, cooperative, and oriented to time, place, and person. He is moderately built and nourished. He has an ECOG performance score of 0, with a BMI of 18.5 kilogram per meter square. There is no pallor, icterus, clubbing cyanosis, generalized lymphadenopathy, or edema. Vitals where pulse rate were 84 beats per minute. Blood pressure was 120 or 88 millimeters of mercury. Respiratory rate of 16, and he was afebrile. Systemic examination, cardiovascular system was within normal limits, and nervous system was also, there was no focal neurological deficit. Respiratory system, bilateral normal vesicular breath sounds were heard. Per abdomen was soft and non-tender. Coming to local examination of neck. On inspection, there is no visible swelling, no laryngeal widening, no scars, sinuses, fistulas, or dilated veins. Trachea appears to be central. On palpation, inspectory findings were confirmed. There is no laryngeal tenderness or laryngeal widening. Laryngeal crepitus was present. There is no palpable swelling or any lymph nodes, and trachea is central. Coming to...
just a minute, how do you say laryngeal widening?
Sir, there will be splaying, sir.
As such, there are no criteria.
Yes, sir.
Based on our routine clinical evaluation, compared to that, if you find the front part of the laryngeal cross widening is the only thing which can be made out clinically.
Yes, sir.
Subclinical is difficult to make out. Okay, and if there is a laryngeal widening,
Yes, sir.
Directly translates the whatever lesion it is to which stage.
Sorry, sir, I didn't hear you, sir.
If you find clinically a laryngeal widening, it
Yes, sir.
correlates with what stage?
The T4A, sir, it shows extra laryngeal spread of the lesion, sir.
That's true. So early T4A may not be obvious.
Yes, sir.
But if you have a gross laryngeal widening, it correlates with the advanced disease.
Yes, sir.
Yeah, proceed.
Coming to flexible laryngoscopic examination. So there was an ulceroproliferative growth noted over the left false vocal cord, going into the left true vocal cord and obscuring the view of the anterior commissure and partly the right true vocal cord. Left hemilarynx was fixed. However, the vallicular base of tongue epiglottis, left aryepiglottic fold, right false vocal cord, true vocal cord, right arytenoid, right aryepiglottic fold, bilateral piriform sinus post-cricoid area and subglottic sphere were normal. The nasal endoscopic examination and esophageal examination were normal.
Harish, can I intervene?
Yes,
What about the mouth opening of the patient?
ma'am, mouth opening. Ma'am, mouth opening, he has a good mouth opening, ma'am. Admits about 3 fingers with an interincisor distance of 4 centimeter. He has a dentate mandible. There is no sharp tooth, dental caries or loose tooth. However, he had nicotine stained mucosa. The tongue movements were normal. Base of tongue was soft on palpation. The tonsil, posterior pharyngeal bone and soft palate was normal, ma'am.
Okay.
Can you go back to the video again?
Yes, sir.
Yeah. How do you say the hemilarynx is fixed, ma? What did you notice in this video? It again.
Sir, the true vocal cord is also not, the arytenoid is also not moving, sir.
True vocal cord is not exactly visible, no?
Sir.
Yeah, the tumor, the vocal cord below the tumor is not visible. What is visible is only the arytenoid.
Yes, sir.
Isn't it?
Yes, sir.
So how to say this is truly fixed or it is?
Sir, once we can confirm it by doing a direct laryngoscopic examination, sir.
That's why the correct word would have been the vocal cord underneath the lesion is not visualized.
Yes, sir.
And the lesion is bulky.
Yes, sir.
And because of that, the arytenoid is not moving. So now comes the question.
Yes, sir.
What do you want to call this lesion as? It's sitting in which part of the larynx?
Sir, it's an exophytic mass, sir, sitting, over the supraglottic region, sir, over the false vocal cords.
Mainly it is sitting in the false cord. No?
Yes, sir.
A fold is not involved. P fold is also not involved.
Yes.
Grossly arytenoid is also not involved. Epiglottis is also not involved. Petiole might be involved.
Yes, sir.
The lesion is mainly sitting in the false cord.
Yes.
So in such cases, if the vocal cord is fixed, what will be the criteria of fixity?
Sir, because of the
bulk.
Sir, if it is one bulk of the tumor, or if it is going into the through the paraglottic space, if it goes into the true vocal cord, sir.
And next one is?
Sir, one is the bulk of the tumor, and second, if it is it becomes a transglottic growth going to the true vocal cord through the paraglottic space.
All the paraglottic space is there, then it will involve the vocalis and intrinsic muscle.
Yes, sir.
And posteriorly, what it can involve?
And what else? What else can cause vocal cord fixity?
Sir, one is the cricoarytenoid joint can be involved, or the if the recurrent laryngeal nerve or the muscles, sir. Vocalis.
Yes. And
So,
what is the? Yeah, go ahead, madam.
Yeah, please continue. Please continue.
Yeah, I wanted to ask, based on your history, what do you think the epicenter of the tumor is?
Sir, it looks like the recent lesion is appearing from the false vocal cord, sir.
It's a supraglottic lesion because patient initially presented with foreign body sensation in the throat, not
Yes.
a voice change. Subsequently, developed voice change. That means that the tumor progressed into the vocal cords.
Yes, sir.
Okay.
Yeah.
Arish, what do you mean exactly by a transglottic carcinoma?
Ma'am, any lesion which transfers through the ventricle is called a pure transglottic tumor. So,
So
it
can you tell me who coined this term called transglottic carcinoma? Who is the first person who coined this concept of transglottic carcinoma?
Krishner, ma'am?
No. It is McGovern, and there are 4 pathways for a transglottic carcinoma to occur. So can you tell this? You have tell 2 situations how a tumor can become transglottic. What are the other ways a tumor can become transglottic?
Ma'am,
So it is a carcinoma which crosses the apex of the ventricle. So any tumor which trespasses the apex of the ventricle is transglottic. So what are the 4 ways how a tumor can become transglottic?
ma'am, first one is which the origin of the lesion is in the ventricle. Second thing is it is from the false vocal cord. It can go through the paraglottic space and go into the true vocal cord, and then it can become a transglottic tumor. Or from the true vocal cord, it can come into the false vocal cord. And
so there are 4 ways: one through the paraglottic space, through the anterior commissure, through the vocal process of the arytenoid, and through the ventricle. These are the 4 ways how a tumor can become transglottic. Okay, proceed. And in the examination finding, as Chavan sir said, you are not able to see the left vocal cord properly. So in such a situation, better not to write subglottis within normal limits. Okay, you are not able to see even the left vocal cord properly in the laryngoscope, radiolaryngoscopy. So in such a situation, better not to mention the subglottis within normal limits. We have not seen the subglottis
Not
properly.
visualized.
Better, it is. You can say that because of the bulkiness of the tumor, you are not able to see the left vocal cord and also the subglottis. That will be the better version to describe the tumor. Okay. Yeah.
Just
Please.
one more, ma. When you discuss supraglottic tumor, you divide it into one main criteria. Can you tell me that?
Sir, it can be divided into suprahyoid, both
And
or
infrahyoid. So where does this tumor fit in?
Sir, it looks like an infrahyoid growth, sir.
How does really it make much difference in suprahyoid and infrahyoid tumors?
Sir, infrahyoid tumors has a tendency to go into the preepiglottic space, sir.
Correct.
Yeah.
Paraglottic space.
Yes.
Glottis. Airway obstruction.
Yes.
They are technically surgical cases compared to the suprahyoid epiglottic lesions.
Okay, sir.
Isn't it?
Yes, sir.
So suprahyoid epiglottis will involve base tongue vallecula, and if at all you want to treat them surgically, then it becomes an extended laryngectomy, base tongue resection, which are in some institutions not a straightforward surgical cases. So they become surgical cases compared to these supraglottic.
Yes.
Okay.
Arish, clinically, how will you pick up there is pre-epiglottic space involvement? Which are the clinical findings that will give you a clue that the pre-epiglottic space is involved? So you have to look into the vallecula. Actually, is there any bulge in the vallecula, or is there any ulceration in the vallecula, or if there is any fullness in the thyrohyoid membrane? These are the 3 clinical signs which will give a indirect clue that the pre-epiglottic space is involved. Okay, so even these
or
type
epiglottis is hanging behind.
And yes, exactly. So these are the 4 signs which will give a clue that without a radiological evidence, you can pick up that there is a chance of involvement of the pre-epiglottic space. Okay.
Proceed, ma. You can. You have anything else to say, or you want us to ask regarding?
Yeah, could you summarize the history and the clinical findings and give your
Yes.
diagnosis?
Sir, so my patient is a 51-year-old farmer who has a history of tobacco smoke, BD smoking for
Only positive findings.
Yes, sir. 51-year-old farmer by occupation with a history of addiction history of BD smoking for 15 years, with history of uh, foreign body sensation for 5 months and hoarseness of voice for 4 months, and referred otalgia. And with on examination, he has exophytic proliferative growth in the left false vocal cord, obscuring the view of left true vocal cord, and with fixed left hemilarynx.
You want to still stick on to fixed hemilarynx?
Sir,
What was his voice? Was it hoarse or it was relatively normal?
sir, it was hoarse, sir.
Okay, you can put it as plus or minus.
Okay, sir. Okay, sir.
Because we are not at based on clinical history, we are not at judge that whether the true calls are really involved or not.
Yes, sir.
Yeah, what is your provisional diagnosis?
Sir, it seems mostly a malignancy of the larynx, the subside being the supraglottis, sir. And clinically, the stage being sir, T3 N0 M0, sir.
So no palpable neck nodes.
No, sir.
So how do you work up this case?
Sir, initially after the examination, sir, I would want to take the patient for a imaging first. So I go for a computer enhanced computer tomography of the neck and chest, sir. And after once
Contrast enhanced or non-contrast?
Contrast enhanced, sir.
Okay.
Of the
From what level to what level?
Sir, from neck to T12, sir. Base of skull to T12, sir.
To mediastinum.
Yes, sir.
Nowadays, what has happened now with the CDs available and packs available, what you are saying is technically feasible. But if somebody has to give you CT films,
yes, sir.
Is it feasible to give you so many films of neck film? So what exactly is the area of interest when you have to write to the radiologist?
Sir, neck and chest.
What do you want to do a chest CT scan?
Sir, first is because as the patient is a smoker, sir, one thing we want to rule out whether there is any distant metastasis, and second thing to screen for a lung second primary, sir.
What percentage do you really find neck lung mets in supraglottic lesions? No?
Upfront.
Yeah.
In
your
I'm not sure,
till
sir.
now, how many cases of CS supraglottis you have seen with lung mets?
I'm not sure, sir. The incidence, sir.
Means it is quite rare, no?
Yes, sir.
It's very rare. It's very rare.
So bombarding all patients with CT chest to rule out a very minuscule number of metastases is technically not advisable. It's a chest X-ray still remains a standard of investigation for lung, which is both fitness and as well as metastasis.
Yeah. Yeah, I agree with sir. And if you are working in a research constraint setting, I would order a CT scan from the level of the skull base to the clavicle with chest X-ray to rule out any lung pathologies.
Yes.
And just to add on.
And what are the section size? What that is more relevant?
Yeah.
For a supraglottic tumor, what sections will you take? At what millimeter?
Sir, we can ask for a high resolution cut, sir, of 0.7 mm, sir.
For a supraglottic tumor?
We are not doing cochlear implant here, no?
Sir, 2 millimeters.
2 may be fine. Even if you ask, it has to be higher to cricoid is what? your area of interest.
Sir.
So that needs to be of 1 mm or 2 mm.
1 mm.
So 1 mm is ideal only in this area. Rest of the neck you can have 1 centimeter, half centimeter cuts.
4 millimeter cuts, 4 to 5 millimeter cuts.
Yeah, 4 to 5 millimeters.
Yes, sir.
Okay, how does cross-sectional radiology help in assessment of tumor? What is that which you are not able to make out in endoscopy, which you will be able to see in cross-sectional radiology?
Sir, in the imaging, once we can see the extent of the tumor, we can see the involvement of the pre-epiglottic and the paraglottic space, sir.
And
if
you are not able to see true
it's the cartilage erosion, sir. If there is
one important finding, did you mention is the patient aspirating? As
Yes,
per your
yes,
history, patient is not aspirating, isn't it?
sir, no, sir.
Does not give any history of cough on swallowing
Taking it.
liquids.
Yeah.
No, sir.
So lateral extension and inferior extension exterior extension are the things which will not be visualized in endoscopy.
Examination, sir.
So which can be seen in cross-sectional radiology. Like paraglottic space, you cannot make out on endoscopy, which you will be able to see in CT scan.
Yes.
Similar way, true chord and transglottic extension and subglottic extension also, you are not able to make out on this
Yeah.
video.
Yes, sir.
So that you will be able to make out on endoscopy.
Yes,
Then
sir.
comes inner cartilage or anterior commissure extension, which is again difficult to make out on endoscopy, which you will be able to see in
CT scan, sir.
CT scan.
So the vertical extent here, since the subglottis is not visualized, even bulk of the lesion is not visualizing the vocal cords in the subglottis, the vertical extent is very important, and the CT will definitely help in assessing the vertical extent of the tumor also. Okay.
Yeah, Dr. Arij, I have a question for you.
Yes, sir.
Would you not do a imaging for this patient?
Sir, yes, sir. Imaging, we'll do a CT scan, sir.
Always do an imaging for all cases of CA larynx. We practice evidence-based medicine. However, we also need to do a direct laryngoscopy, or especially for a laryngeal case, do a direct laryngoscopy for the reasons mentioned by Dr. Chavan sir. You have to assess the arytenoids. Is it truly fixed or not? How do you differentiate whether it's truly fixed or whether the bulk of the tumor is affecting its mobility? How do you assess that?
Sir, we can once we have suspended the larynx, sir, we try to move the required joint, sir.
And one more, when do you do a direct laryngoscopy? Your fiber optic laryngoscopy is showing you the entirety of the tumor. Of course, you're not able to visualize the subglottic region, which you can visualize on CT scan.
Yeah.
So when do you do this? Because if you are planning on doing a direct laryngoscopy, you would have to take consent for tracheostomy. So in this case, would do a direct laryngoscopy just before
surgery, sir.
But would you do surgery for this case? For that, we have to discuss the imaging. So what are the imaging findings?
Sir, in this patient, sir, the contrast enhanced imaging of as showing the axial section, sir, shows a heterogeneously enhancing lesion, sir, in the left false vocal cord, and partly going into the arytenoid, and it is involving the left paraglottic space and going anteriorly also, sir.
So deeply infiltrating tumor involving the paraglottic space.
Yes, sir.
Is it involving the anterior commissure?
Sir, anterior commissure, there is a fat planes are maintained, sir. There is a plane there.
Are you able to assess whether anterior commissure is involved or not based on this imaging? Clinically, it looks like anterior commissure appears to be involved, or at least tumor is reaching the anterior commissure. Okay. One of the ways to differentiate is do a direct laryngoscopy, actually assess the tumor.
Sir.
It's clinical radiological assessment, or not only clinical, not only radiological.
Okay.
As per this imaging, the subglottis appears free.
Yes,
but based on your laryngological examination, you will not be able to comment whether subglottis is free or not.
Yes, sir.
Okay.
Okay.
What else? Neck notes.
Sir, there are no radiologically there are no notes noted, sir.
on
No,
radiological examination.
what clinically you didn't see, will we be able to see radiologically, neck nodes?
Yes, sir.
Is it?
Yes, sir.
Oh, what is the radiological hallmarks of a positive neck node?
Sir, the nodes will be round in shape and
Yes.
What is
and
the, yeah, what sir wants to ask is what's the sensitivity of CT scan in detecting malignant neck nodes? What is the sensitivity of clinical examination? Various modalities are there, ultrasonography, MRI. So could you throw some light on this?
sir.
There are meta-analysis on this by Leo et al.
Layout, sir,
You should read this. Read
Yes.
that meta-analysis.
yes,
Okay.
You should
What-
have 4 criteria. One is size. The neck node should be around 1 centimeter.
1 centimeter.
It should have a oval shape with central necrosis and peripheral enhancement.
Yes, sir.
So all these things will be visible only when the node is more than 1 centimeter.
1 centimeter.
Less than 1 centimeter, unlikely to be picked up by radiological finding. It will look like a reactive node.
Yes, sir.
So there won't be any central necrosis and peripheral enhancement. And neck cuts are usually taken half a centimeter. So if the node is less than 1 centimeter, it might get missed out on the CT film.
Yes.
If you have a CT CD or PACS, then you may be able to identify. But like in this case also, only 3 cuts. One is in supraglottis, one is at the glottis, another one is at subglottis. So it is not really a representative of CT larynx, no?
Yes, sir.
The same thing happens with neck node also.
Sir.
So if the node is clinically palpable, then radiologically you can correlate. Something which is not clinically palpable or technically difficult to pick up on radiology.
I disagree with this, sir. Now that is an old statement. Now CT scans are fairly accurate, and yes, you will not be able to detect 100% of the nodes, but the sensitivity is in the range of 80 to 90% if you take both CT and MRI, and definitely it is better than clinical examination.
Will it
If you
pick up
take,
which is one less
yes,
than
yes,
1
definitely it will pick up.
If it cut goes through that only, no? What I was
Yeah,
saying
see, I
is,
agree with the statement that on the limited cuts that is available, you will not be able to pick up, may not be able to pick up.
unless
But
you
yes,
have a
if you have
PACS.
PACS on the radiologist will tell you if he's a good enough radiologist, he will tell you
you need-
because central
you need
necrosis
to-
can be seen in a node which is less than a centimeter.
You need to spend a little more time and go through each cuts, then you will be able to pick up. But the way the films are given now in peripheral centers, it is difficult to identify. You can miss out on. Even if it is there, you can miss out. The film may not contain the node.
Okay.
Okay, now based upon this radiology and clinical findings, can you restage your lesion?
Sir, based on the radiology, sir, it is CT3.
You are upstaging or you are downstaging, or you will still stick on to?
I'll stay at T3, sir, because of the paraglottic space involvement.
Yeah.
Okay,
Hari.
which we did discuss here is cartilage involvement. No?
Sir, sorry, sir, I couldn't hear you, sir.
Laryngeal cartilage involvement.
Is it involved or not?
On cross-sectional radiology.
Sir, it is not involved, sir, in cross-sectional imaging, sir.
So what are those findings which you will highlight?
What are the signs of laryngeal cartilage involvement?
Sir,
This is what sir wants you to tell.
Once is we look for sir, sclerosis, erosion, lysis, and lysis, sir.
What is the most sensitive sign which tells you that there is laryngeal cartilage erosion?
So sclerosis is the most sensitive, sir.
I think
Not
if
the
you
most
know
sensitive.
about Becker's criteria for the
Criteria, yes.
yeah, what is the Becker's criteria, Reach? You know about Becker's criteria?
Yes, ma'am.
There are eight criteria. Of this, one is more sensitive, and some points are very specific. So we have the sensitive findings and which are specific findings according to the case criteria?
Ma'am, most specific is erosion. Sclerosis is the most sensitive.
Erosion and extralaryngeal soft
Exactly.
tissue tumor. That is
Tumor
the most specific
big finding. If you find disease on the outer surface of
Surface
the
of the cartilage.
cartilage, that means that there is
frank
clear-cut sign of cartilage erosion.
Sir.
All right, that's the most sensitive.
Sir.
And yes, then
that's the most specific, and sensitive is the
sclerosis is the
of
most
the
sensitive.
cartilages is the most sensitive. Okay. So are you in this CT films, actually very limited films, do you find any findings suggestive of cartilage erosion?
Ma'am,
you give your answer. Yeah, you give your explanation.
Ma'am, one area looks doubtful, but it is not a through and through erosion. But
if you have doubt, what investigation would you ask
you
for?
should get a contrast
Yes.
and MRI if you have a doubt of cartilage erosion. Sir.
Then what will MRI tell you?
Sir, MRI is more sensitive to tell if there
Cartilage
is a
erosion.
cartilage erosion, sir.
Yes. If you are in doubt, you can always ask for an MR at that level, a limited MR, not from the skull base to the clavicle.
Clavicle, sir.
You can complement the CT with an MRI
Yes.
to pick up the cartilage involvement if you are in doubt with the cartilage involvement as per the CCT. Okay.
And Dr. Adej, why are we so concerned about whether cartilage erosion is there or not? How does it influence treatment?
Sir, if there is a cartilage erosion, this tumor becomes upstage to T4A, sir, and which we cannot take. Then the patient goes directly for a total laryngectomy, and we cannot go for any organ preservation strategies for the patient.
Arish, the
Yes.
answer should be in such a way that if there is cartilage involved, if you know the cartilage is involved, the treatment modality
Will be
will
surgical.
change. That is,
Yes.
it will change from a non-surgical to a surgical option. So,
Yes,
don't tell the total laryngectomy.
Total
upfront.
laryngectomy,
You can
see,
tell
some of us, especially Chavan sir, he is very well versed in doing near total laryngectomy.
near
Now, if you
total
say that you
laryngectomy.
are
So-
doing total laryngectomy, so he may take offense. So now,
So,
what are the
yeah,
criteria
so
for
better not to.
Yeah. What are the criteria for deciding a patient for near total laryngectomy?
Sir, if it's a lateralized disease, sir, and if the interarytenoid area is free, or we can preserve one cricoarytenoid unit, sir, joint unit.
So the interarytenoid region is free in this case?
Yes, sir.
Appears to be free as per the imaging.
Yes, sir.
And as per your findings, the anterior commissure is also free.
Sir,
Subglottis is also free.
free, sir.
So don't say total laryngectomy in this case.
Yeah.
It will be a non-surgical surgical.
Yeah, you can put it as the case gets converted to surgical case
Sir, sir.
rather than a
Yeah.
non-surgical case.
Yes,
Yeah, that should be your answer. The modality of treatment will go from a
More in favor of
to a
surgical.
surgical.
That surgical could be supraglottic laryngectomy, near total laryngectomy,
Laryngectomy or a
cricoidoplasty,
laryngectomy.
or total laryngectomy.
Yeah.
Okay, sir.
Now,
All right.
Okay, continue.
is it possible to do supraglottic laryngectomy in this case, ma?
Sir, in this case, sir, it is not possible because if it's a supraglottic laryngectomy, the lower cut should go through the ventricle. In this case, after we
Ventricle may be free, no? I'm not seeing any.
sir, but the cord
Have you done a direct laryngoscopy?
direct
on this?
laryngoscopy examination, sir, and if we see that if the true
No, have you done this?
yes, sir.
What is the direct laryngoscopic findings?
Sir, the true vocal cord is fixed, sir.
Okay. And how do you assess the
What about
fixity?
You didn't do total direct laryngoscopy, ma? For that, this patient will require tracheostomy, the way the tumor is.
Exactly.
You are confusing with
Arish, could you-
your FOS.
FOS, sir, sorry, sir.
So direct is different and fiber
Yes, sir,
optic
sir,
is
yes.
different. If you
Both
have to
sides.
do a,
Yeah.
like I mentioned before, if I have to do a direct laryngoscopy, in this case, I would take consent for tracheostomy. With such a bulky tumor,
Tracheostomy.
you
True.
cannot escape doing a tracheostomy in such a case.
Yes, sir, yes.
So imaging is telling you that there is no cartilage erosion. So what is your treatment plan?
Sir,
It's a bulky tumor.
Sir, as this patient does not have any features of aspiration or airway compromiser or a dysfunctional larynx, we can consider the patient for organ preservation strategy like concurrent chemoradiotherapy, sir.
You base it on certain evidence.
Sir, it is based on this Veteran Affairs trial, and where
Veterans Affairs was for induction chemotherapy.
It is not. It was not based on Veteran Affairs. What is the evidence base for the concurrent chemoradiation?
RTOG 911.
RTOG 91. What were the three arms?
RTOG
Can you explain
90.
Yeah, could you explain RTOG 9111 trial? What were the three arms in the trial?
So, sir, there were three arms where they recruited patients. Like one arm was of a concurrent chemoradiotherapy arm, one was induction chemotherapy followed by radiotherapy, and the third arm was a radiotherapy alone arm, sir.
So what were the findings?
Sir,
At 3 years, at 5 years, and at 10 years?
Sir, so at the end of 3 years, the laryngeal preservation rate was maximum for the concurrent radiotherapy arm, about 88%, sir. And
It's at 88%.
ma'am,
What is laryngeal preservation rate for concurrent chemoradiotherapy and reported?
ma'am, at the
It is at the end of 3.8 years, what's the laryngeal preservation rate for concurrent chemoradiotherapy?
ma'am, at the end of 3 years, it was about 88% in the concurrent radiotherapy arm, and at the end of 5 years,
It is 84 rate.
Yes,
It's
ma'am.
84%.
It was 84%. It is 84%. It is not 88%.
Okay, okay.
It is 84%. So they have updated at 3.8, 5 years,
5 years and the
10
10 years.
years.
Yes, ma'am.
Yeah. So it is 84. And what about for the injection chemo? What was the rate for laryngeal preservation rate?
For ma'am, at the
Yeah,
end of
I just looked it up, madam. At 3 years, it was 88. At 5 years, it was 84. And at 10 years, it was
It's
was
at
81.
laryngeal preservation rate. It's 88 days at 3.8 years.
Yes. So I just have it in front of me. Thank you. Yeah, go ahead.
I am also looking. It is in front of me. It is written as 84%. Maybe some mistake.
Yeah, 84
Okay,
maybe.
carry on.
so,
Yes.
ma'am,
Okay, so among these three arms, as per RTO 9111, what was the main conclusion of RTO 9111, Adish? That you should know, no? What is the main conclusion of RTO 9111?
So with this, the loco-regional control was maximum for the CTRT arm, ma'am, and the laryngectomy-free survival was also comparable in the CTRT arm with the induction chemo arm when compared to radiotherapy arm.
What about the overall survival across the three arms?
Ma'am, it was similar across all the three arms, ma'am.
What are the reason for that?
What is the reason for the similar overall across it? Even if you have said that, you can see there is a good loco-regional control or the laryngeal preservation rate was also good in concurrent chemoradiation. The overall survival remains almost similar across the three arms. What is the explanation given by the trial group for this finding?
Ma'am, because some of the patients had to undergo salvage laryngectomy after this, ma'am, and post laryngectomy, the survival improvement.
So, what is the problem with the adding of chemotherapy to radiotherapy? What is the main problem?
Ma'am, the toxicities were increased. The toxicities increased, and once they looked at the 10-year post RTOG trial, they saw that there were non-chemotherapy deaths were increased. There were a lot of not treatment-related deaths in the concurrent chemotherapy arm.
What could be the reason for this?
Yes.
Sir, maybe because the patients could not come. So one was dysphagia was one thing, sir.
Does dysphagia cause death or something else causes death due to this? Complication
Aspiration,
of dysphagia.
aspiration.
What were the how was the complication rate across 3 arms? Which had the most complications? Treatment-related complications.
Sir, concurrent chemotherapy arm had the maximum number of complications.
What were the complications like?
Sir, mucositis and
How do you grade mucositis? What is ETC criteria for mucositis?
sir, I'm not sure. So grade 3, I'm not sure, sir. Grade 3 mucositis were higher, sir.
Grade 3 and grade 4 mucositis. How does what proportion of patients develop aspiration post chemo radiotherapy? This is not just in RTOG 9111. What is the range of this aspiration in patients who receive CTRT for larynx and hypopharyngeal carences? And what predicts tube dependence? Could you name some? So patient coming to with aspiration, difficulty in swallowing. Do you expect him to have aspiration and dysphagia post-treatment?
Sir, those patients which pre-treatment, those patients which had aspiration have more tendency to have aspiration post-treatment also, sir. Post-radiotherapy also, they do worse.
Was there any
So,
recommendations made by laryngeal consensus group? What were the recommendations as per them? What did they say? What should be the criteria for any laryngeal cancer?
So, sir, any patient who had
Arlene Forestier has given a
Laryngeal
recommendation.
conservation consensus. The
Yes.
recommendation panel.
Yes.
For
2017.
patients for organ preservation. 2017, there is an organ preservation. Who should be taken for organ preservation protocol? There is a recommendation panel.
Yes, ma'am.
So you
I hope
said
you have
that
read
the
this.
patient,
Said yes.
if a patient has a pre-treatment aspiration, will we go for a organ preservation protocol?
No, ma'am, because he
Yeah.
has.
So that cannot be, you cannot give a statement. If a patient has a pre-operative aspiration, then post-operative definitely. So that candidate is not the right candidate to go for organ preservation protocol, right? Yeah.
That's why
Yes.
all patients who are considered for organ preservation protocol should undergo a speech and swallowing evaluation.
Pre-operative.
The initial
Exactly.
trials did not have this.
Yes,
So
sir.
many of patients ended up having aspiration in the range of about 40 to 80%.
Sir.
Even in a functional larynx, patient can still have aspiration post-treatment. Just because patient is not aspirating before treatment, that does not mean that patient will not develop aspiration and dysphagia post-treatment. Do you know how to overcome this, or what can you throw some light on this? Like, what are the incidence of post-treatment dysphagia and aspiration? I asked you this question.
Post-treatment.
You should read that. And what proportion of this RTOG 9111 patients were T4A?
Sir, around 10% of the patients were T4A patients, sir. Most were supraglottic patients, sir.
How many underwent salvage laryngectomy? There's an article on that also.
Around 44% of the patients
Rahul, could you mute yourself? Yes, go ahead.
Sir, around 44% of the patients had to undergo laryngectomy, sir. T4A patients.
Yeah, okay.
Actually, Arish, previously in the RTOG 9111, that was a trial conducted in 91. They just looked into the laryngeal preservation, they looked into the laryngeal functionality they didn't look into. So later on, people started noticing the larynx is getting preserved, but it is not doing their
functional.
function properly. So there is no point in preserving a non-functional larynx. That is why they have come up with a recommendation panel. So whatever you're preserving, it should do the function. Otherwise, there is no point in preserving the larynx and later this larynx getting knocked off.
Yes,
So
ma'am.
that is why this recommendation, you have to go through that recommendation by Arlene Forrester, and it's very beautifully given what all evaluation has to be done prior taking the patient for an organ preservation protocol. Okay.
Yeah.
Please.
Good.
Yeah.
Dr. Arish, what assessment would you do for this patient, and what do you do in your center? How do you assess swallowing function and speech?
Sir, we go for a swallowing assessment by functional endoscopic evaluation of swallowing, sir, by fees test, sir.
Is it functional or is it fiber optic?
Functional, sir.
Are you sure?
Sir.
It's fiber optic endoscopic evaluation of
It is
swallowing.
fiber optic. Fiber optic, some people say.
It's functional endoscopic sinus surgery. So
It is
don't confuse.
fiber.
Yeah.
confuse it.
No.
It's fiber.
She's confusing it with FES and fiber
FES and then
optic.
fiber optic
So it is fiber
endoscopic
optic
evaluation.
endoscopic evaluation of swallowing. Between these two, which is better? Both are similar. All right. In larynx and hypopharynx, fees is as good. So you do fees.
Yes, sir.
And what did you find in this case?
Sir, this patient did not have an aspiration, sir. We look for the penetration aspiration score, sir. And we check in terms of both solids, liquids, and semi-solid diet is given to the patient, sir.
Okay,
But-
the patient was not aspirating.
No, sir.
Okay. So what treatment have you planned for this patient?
Sir, this patient we have planned for concurrent chemoradiotherapy, sir.
I think we moved on to CTRT too early. The question should have been, how will you proceed after your radiological investigation? No? How do you want to prove this malignancy?
Yeah, we are not done a
Rest of the
biopsy yet.
people,
Yeah.
sorry, it should have been here. I think somebody has asked. So can you just give what will you answer? How will you proceed now after the cross-sectional radiology?
Sir,
How will you prove the disease?
How do you prove? Legally you have to prove that it is a malignancy. Without that, you cannot proceed with any form of treatment.
sir, in this case, we can go for in this case, biopsy by a flexible laryngoscopy only, sir.
How did you proceed? How did you get a tissue diagnosis in this patient?
We did a
By
flexible.
flexible endoscopy. Yeah. Since it is a proliferative mass lesion and a proliferative exophytic lesion, by flexible endoscopy, it's easy to get a biopsy without causing much problem to the airway. How was the airway at the time of this thing? That is more important. Even if you are doing flexible endoscopy and biopsy, you have to take a consent for a tracheostomy at any time. Since he's a smoker, even a trickle of blood can cause laryngospasm. So even if you are going for a flexible endoscopy, always take a consent for tracheostomy and proceed. Since being a proliferative lesion, there is no difficulty. And what was the histopathology?
Ma'am, it's moderately differentiated squamous cell carcinoma.
Moderately differentiated.
Yes, sir.
The exam answer should be gold standard is direct laryngoscopy.
Laryngoscopic examination.
Assessment of the lesion, whatever Dr. Ratan was telling, you want to assess subglottis, anterior commissure and all those things, and then end with biopsy.
Yes, sir.
But with advent of FOLs or 90-degree endoscopy or people do under local, so the biopsy can be done at OPD basis also,
Sir.
but it is not yet considered as gold standard.
Yes, sir.
Gold standard has to be
Direct laryngoscopy.
biopsy, and real biopsy may make this case go for tracheostomy.
Tracheostomy, sir.
And some busy institutions like yours and ours, where even sometimes the airway is borderline, and if you don't have FOL, we have a publication wherein which we have done translaryngeal FNAC, but you cannot say this as an exam answer. So this is to avoid tracheostomy. Patient doesn't give you consent for tracheostomy, but you have to prove a malignancy.
So,
So the way to prove is either FON or 90-degree endoscopy or translaryngeal FNA. Now tell me, if somebody has done a tracheostomy in the process of proving a malignancy,
sir,
will this case fit into dysfunctional larynx and warrant surgical treatment, or it is still feasible for organ preservation protocol?
sir, this we are doing tracheostomy for the biopsy purposes, so that we can.
In case of supraglottis, if the patient has ended up in tracheostomy due to too bulky or pedunculated lesion, or somebody tried to do biopsy and they couldn't extubate, so they ended up doing tracheostomy. So your staging is still T3N0M0. It is a tracheostomized case.
Yes,
So in
sir.
that case, will your non-surgical treatment feasible, or it will go for surgical treatment?
So we can consider non-surgical treatment, sir, because we can.
Correct. There is a Jatin
That
Shah
is a Ralph.
says that supraglottic lesion where you have done tracheostomy for airway obstruction, but it is still not a dysfunctional larynx,
Dysfunctional
because
larynx.
once the tumor shrinks, the functions of
The
the larynx
vein-
can come
sir.
back.
Yes.
So it is still feasible. But what are the drawbacks of non-surgical treatment?
Sir, one is once we are going for a non-surgical treatment, then the option left for the patient, if he has a recurrence, will be a salvage.
Why recurrence? It can be residual also, no?
Yes, sir.
Yeah.
So in case of residual or recurrence, the next line of treatment is salvage laryngectomy.
Yes, sir.
And in some cases, it is feasible to put a TEP prosthesis, or it may not be feasible.
Yes.
So whatever surgical options you have upfront in the form of supraglottis or near total or supracricoid
Sir.
partial laryngectomies, they are all lost the moment you give a.
Radiotherapy, sir.
So this has to be explained to your patients well in advance. Otherwise, he will expect you to give the same kind of treatment in the salvage setting also.
Yes, sir.
Take informed consent from the patient and explain all the treatment options available to the patient, and the choice of the patient has to be respected. If the patient wants surgery, you should offer that to the patient. If patient wants the organ preservation, most patients would choose organ preservation. But yes, if certain patients want surgery, I've seen patients who are laborers, who work in the fields, they don't want to undergo, they'll choose a surgical option. I mean, in our setting, in our hospital, I have not seen any patient choosing or surgery or no, organ preservation. But in certain hospitals, like low resource constraint setting, that is an option many patients choose. So
Sir.
what did your patient choose?
Sir.
After
Sir, after discussing with the patient and explaining the risk benefits of surgery versus organ preservation, patient wanted to go for chemoradiotherapy, sir.
Organ preservation protocol.
Yes.
So what is the organ preservation protocol?
Sir,
what sequence of drugs and what treatment are you giving to this patient?
so sir,
What is the dose? What is
sir,
the dose of the therapeutic agent you are using?
Sir, here we are giving, sir, weekly cisplatin, sir, 40 mg per meter square with radiotherapy, sir, about 60 grays, sir.
60 grays.
40 milligram per meter square cisplatin weekly
Yes.
plus RT. This is what.
RT is 60
This is
grays. What, that is a definitive dose, or when you are talking about radiotherapy, always talk about a range. Okay.
Always.
Yes,
range.
So
What is the
this
range?
60, what is the range? 60. I
Sir,
don't think it is 60.
Range
60.
RT? What
Yes.
is?
Sir, from 66 to 70, sir, radical.
Yeah, definitive dose is 66
Yeah,
to
you
74.
always, this is to 70, 74. That should be the range. Always tell in range, okay? Range. Okay. So what is the difference between the weekly cisplatin and what is the advantage of weekly cisplatin over the conventional 3 weekly cisplatin? Any idea regarding that? Did you go through that trial?
Your own
3
institute has
weekly
published it.
cisplatin versus one. Yeah,
Sir,
3 weekly cisplatin versus weekly cisplatin.
The toxicity were less and patients were more tolerating the 40 mg.
but toxicity is less with weekly. But what is the efficacy related?
It was comparable.
Which one is more efficacious? Is it
Ma'am,
comparable?
100 milli square one was more better, but patient were tolerating the
It's better, more efficacious. But in this scenario, most of the patients will not be able to tolerate a 100 milligram per meter square cisplatin. That is why it's the tolerability, to increase the tolerability, the dose has been decreased. Okay, and 40 milligram per meter square weekly dose.
Yes.
Have you gone through the starter paper, the 3 weekly cisplatin versus weekly cisplatin? Okay,
no.
if you are giving cisplatin, on which all days you will give cisplatin?
Ma'am, if it is a 3
3
week,
weekly.
ma'am, one
3
first day,
weekly.
Thursday and the 43rd day.
First day,
22nd and the 43rd day, ma'am.
Every 3 weeks.
Okay.
Huh.
Can you tell me about GOTEC trial? Do you know about GOTEC trial?
Ma'am, in GOTEC trial, they compared the induction chemotherapy with the TPF versus cisplatin 5-fluorouracil, ma'am.
And what they found out?
Uh, Ma'am, they found that the TPF was control. I mean, the disease control was better with the TPF compared to PF. Ma'am,
Yeah.
platinum.
The
Laryngeal
laryngeal
preservation is
preservation.
better with no
With
difference in
TPF.
survival. All right.
That is a every conclusion they are saying. There is increase in the laryngeal preservation rate, but there is no advantage in overall survival. Okay.
Yes, ma'am.
So after this concurrent, so your patient has chosen concurrent chemoradiotherapy, that is organ preservation protocol. So after the organ preservation protocol, how will you follow up this patient?
Ma'am, once the patient has completed treatment, we call the patient every monthly and we go for a whole body PET scan at the end of 12 weeks of treatment, ma'am.
Okay.
And where we look for any residual disease and the treatment response, ma'am. And
so all patients, irrespective of their symptoms, irrespective of the endoscopic findings, will undergo PET-CT at the end of 12 weeks in your institution?
yes,
See,
ma'am.
the patient is absolutely symptomatic, absolutely
Non-symptomatic.
Non-symptomatic.
the endoscopic finding is also, the patient is asymptomatic, non-symptomatic, and the endoscopy is also minimal edema. But the cord has also retained we were in doubt about the mobility of the left hemilarynx in this condition. But after the concurrent chemo RT, after 1 month, the left vocal cord started moving. There is mobility. So
Yes, ma'am.
in such a situation also, you will go for a PET-CT at the end of 12 weeks. That's a question of doubt I am asking.
First,
Is it feasible
first
for all? Is it feasible for all patients who have undergone CCRT to undergo a PET-CT at the end of 12 weeks? Yeah, that is my question. In such a
so ma'am, here in my institute, ma'am, first post-treatment scan, we do post-treatment, we do a PET-CT, and later on we follow up with the laryngoscopic examination, full examination of the patient, ma'am.
So
Is it mandatory? What
It's not-
madam wants to know is it mandatory to do a PET-CT scan after treatment, post-treatment? Post-treatment 3 months. Is it mandatory?
If it is, if the patient is improving, then it's not required, sir, but I'm not sure, sir.
No.
So that is why the clinical improvement in the disease, clinical response to the treatment is very important. Assessing the clinical response on behalf of the symptomatology, on behalf of the endoscopic findings, then you will look if the patient is having a persistent edema in the post-operative setting.
Yes, ma'am.
What will you do in such a situation? In that situation, it is mandatory to go for a PET-CT. I don't know, it may vary with institutions and institution, but for a resource limited country like ours, it is not possible to do PET-CT for all patients. After
Even we don't order
treatment.
PET-CT for every case. If patient has responded
Yeah,
well
that
and
is
clinically, if it is
Okay.
patient is not showing any signs of tumor, residual tumor or then there is no point in ordering a PET scan. However, if you want to do a PET scan, you can do it at 6 months as a baseline.
Yes.
The other thing is, in case of larynx, there can be false positive PET due to chondritis, but
Yes.
your repeated biopsy can come negative.
Okay, sir.
There is something called as chondronecrosis used by chemoradiation. You may have a dysfunctional larynx and you may have a PET positive, but you will never be able to prove. We have a publication in which we have done salvage laryngectomies post CTRT dysfunctional larynx, and their final HPR is no evidence of tumor, only chondronecrosis.
What could have caused this chondronecrosis, Harish?
Sir, if there is perichondral, I mean, like if there is perichondral.
Repeated biopsy also can precipitate chondronecrosis. If PET is negative, there is no. If you are in doubt, like Madam said, do a PET CT scan. If PET is not showing any uptake, don't do any biopsy. If you do a biopsy, you can precipitate a chondronecrosis.
Yes, sir.
So
That
if
era
you
of
see,
yeah.
if you see persistent edema in the postoperative, we have a tendency to rule out our disease. So it will end up in repeated biopsies, and that will definitely end up in chondroblastoma necrosis. So we should be very judiciously take these patients for repeated endoscopy. So in that scenario, when the patient is having a persistent edema, you have to rule out. You can, like Chavan sir said, even PET CT can cause false positive results because of the chronic inflammation. Okay. So the moral is, if you see edema in the postoperative, don't jump for biopsies. You just see how the patient responds. Go ahead with the PET CT. If the PET CT has got a significant SUV value, then you can try upon that. Otherwise, repeated biopsies will end up in a morbidity. Okay.
Yeah, Aris, 1 year down the line, this patient comes with bilateral stridor, and on your endoscopy, it appears normal, only arytenoids are fixed. What do you attribute it to? The patient comes in stridor, endoscopy, no disease, but both cords are fixed.
What could be the cause?
Sir.
It's
called you heard about radiation-induced cricoarytenoid fixity?
Exactly. So
this also needs to be kept in mind in the follow-up. You can have a stridor, may not be related to disease, but because large dose of radiation has gone to the larynx, and the cricoarytenoid joint is very close by. So that joint can become fixed due to radiation fibrosis.
The laryngeal lymphedema also can precipitate stridor. So that also cannot be ruled out.
Okay, I think we are nearing 7 o'clock.
And what is the gold standard for treatment of laryngeal cancer? If it is a T4A disease?
It's a total laryngectomy, sir.
No organ preservation protocol has, before talking about survival, what is the survival that you expect in a T3 laryngeal cancer? At 3 years, at 5 years, across all studies. T1 larynx, T2 larynx, T3 larynx, T4 larynx.
Sir, T1 larynx, it's 100%, sir.
100%?
I mean, post-surgery, sir.
100%.
What is this?
That means none of the T1 larynx fail?
So there should always be a range at age. Whenever you are talking about their survival,
over 90%.
No oncological treatment will be 100%.
Over 90% across all studies. Okay, certain individuals have over 95%, 97%, so over 90%. What about T2 larynx?
Sir, I'll read, sir.
T3 and T4. About 60%, 5 years average. All right.
I think
and even the survival differs across the sides of the larynx. With regard to supraglottis, glottis. Glottis has got a subglottis. glottis has got a good prognosis when you compare with the subglottis and supraglottis.
Which has
And
the
most
worst
of the
survival?
Yeah.
Which has the worst survival?
Subglottis, sir.
And what is
Why
the peculiarity of subglottic tumor
yeah.
Sir,
compared to glottic or supraglottic?
sir, they present late and they have because patient will have airway obstruction and it can directly spread to the required cartilage. Cartilage erosion is very early subglottic.
And
So the presentation is almost similar to like of a COPD patient. So they will be managed by a physician most of the time as COPD. So once there comes a stridor, then the disease will be in very advanced disease. That is why subglottis is very late in present, very late to diagnose as subglottic malignancy. Understood?
even
That is why.
is there any role of organ preservation in subglottic tumors, Arish? I hope you answered it right.
Sir,
It's a straightforward question.
sir, the T1 tumors, the small T1 mucosal tumors, if we can consider for
I've never seen, yet to see a small T1 subglottic
Yeah,
tumor.
exactly. Very difficult to see a early stage subglottis. Many of these patients, they will present with just dyspnea, and most of these patients will be smokers also. So they will say that it is COPD exacerbation. So very difficult.
Patient will end up with
believe.
TL,
Yeah.
total laryngectomy.
They
There is no
will
role.
end up in. You said you already gave the answer that it will destroy the cricoid very early.
Yes,
Chavan sir is, I mean, I trained under Chavan sir, so I've seen lot of partial laryngectomies and near total laryngectomies. Could you tell me when you can do a near total laryngectomy in a case like this? What is the criteria for doing a near total laryngectomy?
Sir, if it is a lateralized disease and one cricoid joint can be preserved, sir. And if the
What is the requirement for doing a near total laryngectomy?
sir, T4A lesion, if it is a lateralized lesion and if it is not involved
No
in
subglottic, no significant
Arish,
subglottic disease.
Arish, there is no need to say T4A. Even in T3 also, don't say at particular stage. So any lesion where the interarytenoid is free, there is minimal subglottic extension, I mean adequate subglottic extension. And if the other cord, one cricoarytenoid unit is intact and the other cord, half of the other cord should be, contralateral cord should be absolutely free of the disease. And that contralateral cord is very essential to create the shunt. So these are the four criteria. Yeah, myomucosal shunt. So these are the four criteria. Interarytenoid free, opposite contralateral cricoarytenoid unit should be absolutely functioning, and more than one half of the contralateral cord should be free, and subglottic extension should be. See, what is the criteria for the subglottic extension for all these sort of conservation surgeries? Laryngeal conservation.
10 millimeter anterior and less than 5 millimeter posterior.
And this is what is the advantage of near total laryngectomy over other laryngeal conservation surgery? Especially in this patient, if you're opting for a near total laryngectomy, what is the advantage in this patient?
Ma'am, his following
it is not. It is the voice conservation surgery which can be done in a compromised pulmonary function. All the other conservation surgeries, you need a good pulmonary reserve. Understood. So near total laryngectomy or the Pearson surgery is a surgery where you can do even in a patient with a compromised pulmonary function. Understood.
What percentage will have speech in NTL?
Do all patients develop speech?
Sir, yes, sir. We can with the patient will have a permanent tracheostomy, but then if we have do a
what percentage of near total laryngectomies develop speech, and how many percentage they will not be able to speak compared to TEP?
What percentage of TEP develop speech? It's 100%. Is it 100%?
Sir, no, sir.
TEP is 95% and near total is around 85%. Because there is a learning curve in near total. You may have a very tight shunt, or you may have a very long shunt, or you might have not done the shunt properly. There is a learning curve.
Sir.
So all patients may not speak. Whereas TEP, unless they have some laryngeal, neopharyngeal spasm or tight pharyngeal closure, rest all will develop speech. And insertion of TEP is easier compared to NTL. So that is the reason why NTL is not
It's
well
going out of
accepted and marketed by the operating surgeons. So
it has a learning curve.
anyway, last thing, I think we have crossed 7. Have you seen salvage surgeries, salvage laryngectomies, ma?
Yes, sir.
What percentage had complications in whatever you have seen?
Sir, around like 40% of the patient had like most common complications is pharyngocutaneous fistula, sir. And
The reason for asking this is we all propagate organ preservation protocol, but when it fails and you have to do salvage surgery, you can call nearly 40 to 50% will have complication, which is much more higher compared to apparent laryngectomies with TEP.
Yes, sir.
So we have to keep this factor in mind when we are discussing and advising patients organ preservation. I think Ratan and Divya, shall we end up?
Yes,
Yeah,
sir.
yeah,
Sure, sir.
yeah,
Thank
sir.
you.
She,
Thank you, madam.
thank you, thank you, sir. Thank you, sir.
Thank you,
And
sir.
she has answered.
Thank
She
you,
has
Ari.
answered
You did very nicely,
sir.
and I thank organizers of Varanasi for allowing us to discuss this case.
Yeah.
Thank you, one and all.
Thank you,
Thank you everyone for
Asim.
joining. Thank you so
Thank you,
much, Dr.
Asim.
Divya, Dr. Purushottam, and Dr. Ratan.
Dr. Asim,
And
thank you
thank-
so much. Dr. Kamal, Sunena, all of them. Very thank you so much. Very thank you. And Asim, Ari just answered well. Actually, she's a first year person. She has answered. She has went through the articles and she has went through the whole subject and she has done her best. So she has to improve in some aspect. She will read and she will pick up. Okay,
Yeah.
Arish. Good. All the best.
All the best, Arish. For a first year, you have done very well.
Yeah.
Thank you.
Thank you, sir.
Thank you, Arish. Thank you everyone for joining.
Yeah, thanks for the opportunity, Asil. Thank you. Have a great